We now call our next speaker, Dr. Mahesh D M, to speak on hypocalcemia management aspects.
Dr. Mahesh is affiliated to Aster and Aster Hospital, Shashi Advanced Health Center at Bangalore. Numerous publications and presentations, and his areas of interest are pituitary disorders, electrolytes, diabetic foot, and type 1 diabetes. Hypocalcemia is a very commonly seen day-to-day in the day-to-day practice, where patient presents with symptoms of hypocalcemia. So we would like to listen more from this for the management aspect of the hypocalcemia.
Thank you very much for the kind introduction. I thank the entire organizing team for inviting me to Mangalore. So today we'll be briefly talking about managing patients, because that is why we treat our patients when they have a low calcium. We'll see how they come to us and what are the ways in which we can manage them by understanding the calcium metabolism, diagnosis, investigations and treatment. So this is first case. I will go through few cases and then go through the slides. 45-year-old lady, post thyroidectomy. On day 2 started complaining of tingling of fingers, severe muscle cramps, had a positive Jostock sign. So patient was started on oral calcium. On day 3 patient developed seizures. So before ending we'll come back to this patient. So this is second patient, calcium is 7.8, came with muscle weakness, difficulty in climbing stairs for almost 2 years, was indoor most of her life. I am sure you will know the diagnosis. It is vitamin D deficiency presenting because of chronic indoor stay where patient is not exposed to vitamin D at all, which is less common now, but still we see some patients who come with these symptoms. This is one of the third patient, is a female patient with CKD, diabetes stage 4, suddenly came with tetany, confusion and prolonged QT interval on ECG, and 2 days ago patient had received treatment for osteoporosis. So this is one of the drugs that can cause this. Any guess? Yes, denosumab is the drug that the patient received. So denosumab should not be given when the patient already has a low calcium. So always check for calcium level before giving the drug. So this is how the calcium is in our body. Total calcium 99% is in the skeleton, 1% is outside, out of which 99% again is intracellular, and only 1% of it is in the circulation. And in that also we can see that 50% is ionized, 40% is protein bound and 10% is ionic. So when we measure any calcium, it is this 1% calcium that we are measuring. So we should be aware of both total and ionic calcium when we make any diagnosis. This is a complex slide with all the aspects of vitamin D, calcium, phosphorus. We will not get into this. So calcium is very important mainly for 3 major functions, that is the neuromuscular signaling, bone health, and also the cardiac function, blood coagulation and hormone secretion or cellular signaling. Normally the ionic unbound form in the ECF is maintained within an exclusively normal range through a series of feedback mechanisms that predominantly involve the active vitamin D and PTH, and the usual intake recommendation is around 1000 milligram per day. So simplify it, we have to remember that 3 important things that we always want to measure is vitamin D levels, parathyroid hormone and calcium. But the physiology is does not end with only these 3 chemicals. We also have the phosphorus, calcitonin, PTH receptor, the FGF23, active vitamin D, rank ligand, all of this, and the vitamin D absorption, the various receptors that have a role in actually defining the calcium level in our body. So it is a complex physiology that determines, but majority of the cases we need to look at the calcium, phosphorus, PTH and vitamin D to arrive at a diagnosis. So what is hypocalcemia? Hypocalcemia is defined whenever the calcium level is less than 8.5 or when the ionized calcium is less than 4.6 milligram per DL. It can be acute or chronic. It can be mild, moderate or severe depending on the calcium levels and when they present to us. So what are the typical symptoms that we see? Most common is paresthesia, that is tingling numbness. Then we have muscle cramps. Tetany can occur in some patients with carpopedal spasm. Especially we commonly see that in patients who come post-operatively, or those who have chronic hypocalcemia and have stopped their supplements. Proximal muscle weakness is also seen. Patients have seizures, altered sensorium if it is usually acute hypocalcemia, which can also lead to bronchospasm, prolongation of QT interval cardiac arrhythmias. So patient can present with one or more of these symptoms when they come to us. So few of the symptoms can be remembered as cramps, convulsions, reflexes hyperactive, arrhythmia, muscle spasm, positive trozius or Chostic sign, and sensation of tingling and numbness. So the Chostic sign is elicited by hitting with your finger on the zygomatic arch, and you will see twitching of the muscles of the face. The trozius sign usually is measured with usually found out with the help of a BP apparatus, where when you try the cuff above the systolic blood pressure, usually more than 3 minutes, but you will get it within 1 or 2 minutes. You will usually get the sign when the patient has hypocalcemia, and you can see here the patient will have carpal spasm whenever you tie the cuff. So what are the ECG manifestations? Most of the time it is the prolongation of the QT interval, which is inversely proportional to the serum calcium level. So if the calcium level is high, the QT interval will become less, and T wave is usually normal in duration and amplitude. So hypocalcemia is the only condition that can prolong the ST segment without affecting the T wave. So this can be one of the clues in ECG. So what are the common causes? Most common cause is usually the post-surgical hypoparathyroidism and vitamin D deficiency, which can be either because of inadequate intake, malabsorption, or lack of sunlight. The hypoparathyroidism, apart from post-surgical, can be either congenital or autoimmune, when it can be syndromic in terms of either congenital or autoimmune. We also see that in CKD, acute pancreatitis, patients with magnesium deficiency, and also on medications like loop diuretics, chronic PPI use, bisphosphonates. So how do we approach our patient? So like I told you, the first thing we always measure for any patient is the calcium along with albumin. Then we exclude acute pancreatitis, phosphate therapy, or any drug therapy. Then look at the plasma phosphorus level. If the phosphorus is decreased, check the magnesium. If the magnesium is low, it is magnesium deficiency. If the magnesium is normal and phosphorus is low and calcium is low, usually it is vitamin D deficiency. If the patient has increased phosphorus, then first exclude renal failure, then look at the plasma parathyroid hormone. If the parathyroid hormone is high and the renal parameters are normal with the high phosphorus, it is usually hypoparathyroidism. If the PTH is low, it is hypoparas, and if the PTH is high, it is pseudo hypopara, where we have the calcium phosphorus level. So usually calcium phosphorus in majority of the patients is enough along with magnesium. So we usually need these parameters. Sometimes we will need a pH or an ABG or a VBG to help us arrive at a diagnosis in 1 or 2 set of patients, and rarely we require 125 vitamin D, and MRI brain may sometimes be required when the patient has seizures or any other manifestation that can be occurring because of chronic hypocalcemia. So this is something that we usually do in our practice. Is ionized calcium is not always available. So with the help of calcium and albumin, we have to arrive at an ionic calcium level or a total calcium level. So the first thing to look at is if the calcium that we are measuring is correct or not. That depends on the albumin levels. So the total calcium is measured by calculating, the corrected calcium is measured by calculating the total calcium plus 0.8 into 4 minus albumin. So that is usually if the calcium is 8 and the albumin is 3. In this patient, it appears, if you look at only the calcium is low. Is it hypocalcemia? But the corrected calcium you can see is 0.8 plus 0.8, that is 8.8, which is normal. So corrected calcium is important because the patient may be asymptomatic and doesn't actually require the calcium supplements. Look at the albumin, you will probably get a different diagnosis. Ionized calcium is usually an estimated calcium, which is 50% of the corrected calcium. So in this case, if it is 8.8, you can take 4.4 as the corrected calcium. So to briefly summarize the workup for hypocalcemia and the causes, look at calcium when it is low, check the PTH, phosphorus and magnesium. When the parathyroid hormone is low, then you have easy diagnosis, it is hypoparathyroidism. But when the parathyroid hormone is normal or high, then we have to look at various other causes. A high PTH could be because of pseudo hypoparathyroidism, vitamin D resistance, or In patients with CKD also we can see that the patient has a high PTH with a low calcium. Again, look at drugs, calcium chelators, cisplatin, cinacalcid, denosumab, phenytoin, other drugs. It can also be low in patients with acute illness, acute sepsis, acute pancreatitis, hyperphosphatemia, or osteoblastic metastasis or hungry bone syndrome, where we'll have a very low calcium with usually low phosphorus also in some of them. Further, in patients with, why I said we have to measure the VBG or ABG, is that in patients with alkalosis we can actually have a decreased ionic calcium and cause symptoms of hypocalcemia, and usually if you correct the alkalosis the patient improves. So these are the various pseudo hypoparathyroidism syndromes where the calcium will be low, PTH will be high. You can go into the various ways in which we can make a diagnosis, but simplified way is that calcium is low, phosphorus is high, PTH is high. Usually it is pseudo hypopara when the creatinine is normal. So how do we treat these patients? Treatment usually depends on the severity of hypocalcemia and the rapidity with which it is occurring and the accompanying symptoms or complications. Acute symptomatic hypocalcemia should be managed with IV calcium gluconate, which is 10% weight by volume, 1 ampule diluted in 50 ml of 5% dextrose preferably, or otherwise normal saline also you can use over 5 to 10 minutes, which should be given very slowly under cardiac monitoring. Usually monitor the pulse for our patients because they can develop bradycardia and arrhythmia. Accompanying hypomagnesemia, if it is present, should also be treated simultaneously. So how do we correct this in our clinical practice is we have two calcium IV preparation. One is calcium gluconate and the other one is calcium chloride. Calcium gluconate is initially given as 10 to 20 ml of bolus in 50 to 100 ml of dextrose over 10 minutes. This usually gives 100 to 200 milligram of elemental calcium. This is usually enough to, if a patient is having seizures, the seizures will stop usually with one dose. For the other symptoms, it may require more, so the continuous infusion may have to be continued with 100 ml dose of 10% calcium gluconate in 1 liter of 5% dextrose by volume, and then which will be given at 50 ml per hour, which will approximately give 1 milligram per ml of elemental calcium, and the rate should preferably be slow and target an infusion rate of 0.5 to 1.5 milligram of elemental calcium per hour. Currently concurrently also give oral and calcium and calcitriol supplementation. Very important to monitor the symptoms, check the calcium and also look at the ECG if there were any changes previously. The important thing again and again to remember is that this calcium, we have to be very careful when we give it IV, because if there is extravasation, there will be necrosis of the subcutaneous tissue, and even the local extravasation can cause necrosis, and always administer it slowly. So if typically when do we use this IV calcium? Whenever a patient has tetany, muscle cramp or seizures with cardiac manifestations, prolonged QT interval or arrhythmia, when the calcium level is less than 7 or when the ionized calcium is less than 0.8, especially when they are symptomatic, and any patient with acute hypocalcemia, calcium may be 7.5 or even 8 sometimes, but if the patient is having acute hypocalcemia post parathyroid surgery or acute severe pancreatitis, then also we will have to consider the IV calcium because sometimes it can go very fast on a downward trend, and patient may end up with seizures when they are having mild symptoms. So always when the patient has symptoms, be cautious in knowing whether it is an acute or hypocalcemia or a chronic hypocalcemia. In a chronic hypocalcemia, you can take time treat, but in an acute hypocalcemic event, always better to give the IV correction before the patient develops seizures or bronchospasm. Again, remember, caution is extravasation can cause tissue necrosis, especially the calcium chloride, which is given usually on the central line, and it can cause phlebitis, irritation of the vein, cardiac toxicity, that is rapid correction can reduce the heart rate, bradycardia, arrhythmia, or even cardiac arrest sometimes. So followed by the IV, if the patient is stable, you can start the calcium supplements from 1 to 3 grams, and calcitriol can be given from 0.25 to 1.5 micrograms. Treat vitamin D simultaneously and try to bring the calcium level to a low normal range because we don't want to overtreat with calcium and patient develops hypercalciuria, which may lead to sometimes renal stones. The caution is in patients with CKD or pseudo-hypoparathyroidism, we don't want to immediately correct the calcium without bringing the phosphorus down. So always tell the patient to reduce the phosphorus intake orally, whatever, usually most of our foods contain good phosphorus, so milk, chocolates, peas, nuts, all of them have high phosphorus. Try to reduce the phosphorus intake and gradually correct the calcium. Calcium carbonate gives 400 milligram of elemental calcium, and calcium citrate gives 211. Therefore, since it is off, most of the time we prefer calcium carbonate. So when do we prefer calcium citrate? Calcium citrate is usually used when acidic environment is not required. So in patients with hypochlorhydria or those who are on chronic PPI or post gastric bypass, you can use CCM, especially also in elderly patients. So towards the end, we'll go through 3-4 cases and then take some questions. So this is a patient with chronic diarrhea, had muscle spasms, weakness, low calcium. Despite calcium replacement, the symptoms did not resolve, and the next day patient developed paraparesis and weakness of the limbs. Then it was checked, the potassium was low. After corrected, again the patient had recurrence of symptoms. Probable etiology. One of the common things we see is magnesium was low. We all know that low magnesium can also cause low potassium. So if a patient has hypocalcemia or hypokalemia that is not resolving, always check for magnesium and try to correct that simultaneously along with replacing the calcium or potassium. This is one more case, patient with alcohol abuse developed severe abdominal pain, nausea and hypotension. Calcium was 6.8. The next investigation you will think of in a patient with severe abdominal pain with history of alcohol is elevated lipase and amylase. This is a case of pancreatitis resulting in hypocalcemia. This is one more lady who came to ER with tetany. Calcium was 8.1. Patient was given IV calcium. Patient improved, discharged, went back, came same day in the evening with tetany again to the ER within a very short period of time. In this patient, so patient was very anxious, had hyperventilation and improved with rebreathing mask. No need for IV calcium in this patient. When you read, why does this happen? If you look at this pH and calcium, when there is acidosis, the calcium is free, the hydrogen ions are bound to the albumin, whereas when the pH is very high, which happens when you are ventilating, you get alkalosis. When the pH is high, the calcium is bound to the albumin, therefore the ionic calcium comes down. As soon as you take a rebreathing mask, you breathe in more carbon dioxide, your pH level will come down, automatically the calcium will become normal. So in this patient there is no need for IV or oral calcium to be given for getting the patient under control. This is last case is a 15-year-old boy who came with seizures from childhood. MRI was done at the age of 8, it was normal. Patient was on multiple anti-epileptic drugs, still had refractory seizures. Calcium was 6.3, phosphorus 3.5, vitamin D 6. Everything is sort of typically fits into low calcium. Patient is taking anti-epileptic drugs. We all know anti-epileptic drugs can also contribute towards the low calcium vitamin D deficiency. So calcium vitamin D was corrected. After 2 years, patient started developing extrapyramidal symptoms. MRI brain was done, which revealed pseudo-FAR syndrome, basal ganglia calcification. Next time PTH was done, it was 15, calcium was 6.5 and phosphorus was 6.7. So why is this? Is that the vitamin D is so common, that deficiency is so common that we usually treat the commonest cause and think that the patient is probably going to improve. But sometimes we have to see that when vitamin D, calcium is very low and vitamin D is very low, the phosphorus usually will not be normal. Phosphorus will be usually very low or low normal. So a normal phosphorus or a high normal phosphorus should always ring the bill that it may not be a typical case of vitamin D deficiency. Think of other causes. So this probably is a chronic hypocalcemia patient from the childhood had congenital hypophosphatemia. So we'll go back to the case 1. So this patient, I told you, 45-year-old lady, post-steroidectomy, day 2 developed muscle cramps, then Chopstick sign positive, treated with oral calcium, calcitriol, and single dose of IV calcium was given. Patient developed seizures. At the second day, IV calcium was not continued. And then there was history of Graves' disease for 3 years, and patient had a large goiter before the surgery. So this is probably what you want to look at next. We would like to check, give IV calcium as the first choice, check phosphorus and magnesium. Phosphorus, magnesium both were low. This is a case of hungry bone syndrome. So hungry bone syndrome, the acute hypocalcemia is very common, and it can be sort of refractory hypocalcemia, where I have given one patient 7 days IV calcium before weaning off the patient from IV to oral calcium. So it can be very severe, sometimes it can last for many days. So always we need to be careful and aware of this. So this is a small thing, I will not go into this. Towards the end, remember hypocalcemia is very common, timely diagnosis is crucial. Always look at magnesium along with phosphorus whenever you manage our patients, along with vitamin D and PTH. Acute hypocalcemia requires calcium gluconate IV, and chronic we require oral vitamin D, either active vitamin D or regular vitamin D supplementation. Also ensure that you treat the root cause whenever magnesium is low or CKD is managed. Also in high risk population, patient with thyroidectomy or CKD, always monitor the calcium along with PTH in those patients. And those on medications that can affect the calcium or vitamin metabolism, be aware. And also all of us, including doctors, should ensure we take adequate vitamin D and sunlight, because 99% of the doctors have vitamin D deficiency. 1% doctors are those who do not practice.
Thank you, sir. It's a wonderful presentation. So I have one question. Suppose you give IV calcium and the patient gets corrected. After 3 days you do repeat, it's on the lower side, 7.8. You start with the oral tablets, or how do you go about it?
Yes, sir. IV calcium is required only when the patient is symptomatic. The only time we would like to restart is if we feel it is a hungry bone syndrome, that we don't want patient to go down again. Otherwise oral calcium is enough. When it is more than 7, usually they don't require IV calcium.
How long you have to give, sir?
In a post-thyroidectomy patient, usually the requirement is 1 month to 3 months. You have to supplement calcium with vitamin D, active vitamin D. Gradually reduce the active vitamin D first, and then reduce the calcium if you want to see the recovery of the patient, because the active vitamin D can also suppress the PTH. So always withdraw the active vitamin D and then calcium, and then check the PTH whether the patient has recovered post.
Once in 3 months?
No, at the end of 1 month only majority will recover, but it may last.
Checking how often?
Checking monthly.
Monthly. In a elderly, common day-to-day practice, elderly, postmenopausal ladies, they frequently come and ask, should we take calcium, vitamin D?
So most of them will not be taking the adequate, what is required normal calcium intake. So we can say safely that the 500 milligram tablet that is available with vitamin.
Blindly can we give? Or?
Yes, sir. It's better to always screen once the calcium, and if the calcium is normal, we can give safely.
Daily they can take?
Yes, yes. There is no harm. The only thing is that always try to let the patient to take the calcium with the meal or after the meal. That will actually reduce the oxalates and reduce the risk of renal stone, because everybody thinks if I take calcium, kidney stone will be formed. If you take the calcium with meal or after the meal, it will actually reduce the risk of developing renal stones.
Can you take this calcium once or twice a week? Is it of any benefit, or every day? Postmenopausal elderly ladies, 70 plus.
At least alternate day would be sufficient, sir. If not daily. Once or twice a week will not be beneficial.
Thank you. Any other questions?
Because in them even citrate, calcium citrate 211 milligram is enough for them to get enough absorption to take care of their health. So usually half alternate day of calcium carbonate is also enough.
Okay, thank you.
Which calcium is better absorption, calcium citrate or calcium carbonate?
Calcium citrate is better absorbed in those with hypochlorhydria. So that is those who are taking PPI for a long period of time, or elderly patients who have usually some have the atrophic gastritis, so they don't have acidic environment. In them the carbonate absorption is not good. So in that patients you can choose citrate. Carbonate is the best.
Calcium estimation.
Yes, I would not recommend that, because I have seen 2 cases of hypercalcemia in patients who have taken continuously calcitriol with calcium for 6 months. So it is better not to give calcitriol with calcium unless the patient has hypoparathyroidism.
Application of tourniquet before venipuncture for calcium estimation, it's supposed to increase the calcium levels.
Yes, sir, but it may be very marginal. It will not affect the patient with symptoms.
Okay.
Potassium usually is more often raised. Thank you. Thank you, sir.